Hello, everyone. On behalf of the Compass Health Consultancy team, I would like to welcome everyone to this webinar today. And let's get started with our exciting program today. I will start by introducing myself. I am Nathalie Sayer, healthcare advisor and trainer, working with the Compass Health Consultancy as well with other organizations in Saudi Arabia. I have also collaborated with several organizations in Lebanon, including the Ministry of Public Health, the Order of Nurses, and different NGOs. I come from a nursing background with more than 20 years of experience in healthcare management, where I served as nursing director and as a quality director. I will be moderating this webinar today, and I'm glad to welcome you all. And we really appreciate that you all have decided to join us today. And let's just do some housekeeping. First, we want you to know that a recording of this webinar will be shared with all of today's participants after this event. For your questions, please put them at the Q&A box at the bottom of your screen. And we will have time at the end to answer all your questions, hopefully. We want to ask you to please keep your microphones muted. And we have an interactive chat box that is available in your Zoom page to allow you to chat and interact with our speakers. For today, we have a bundle of excellent speakers who will definitely provide interesting presentations that we hope you'll enjoy. Our presenters will share with us important information on how to enhance infection control practices in endoscopy, which is a very important topic. Inadequate cleaning and disinfection of endoscopes increase the risk of infections, and reprocessing of GI endoscope is a complex process, especially with the scope designs. So integration of an appropriate quality assurance program can help prevent the risk of infection associated with endoscopic equipment and accessories. Also, providing adequate training for healthcare professionals in charge of the reprocessing cycle and increasing their competence to appropriately perform endoscopic reprocessing is very important. So throughout this webinar, our speakers will provide you with up-to-date information, best practices regarding infection control in endoscopy, and present practical tools and strategies to implement and maintain stringent infection control measures within endoscopy units. For the agenda for today, it will include the following topics. First, we'll go through the factors at different levels that contribute to failures in reprocessing of endoscope with Jill Holdsworth. Then Bassel Malaeb will walk us through the potential solutions and evidence-based recommendations. Unfortunately, we will not have Nancy Steenbackers with us today for unforeseen circumstances. So next we will have Dr. Mariette Janglout, who will discuss the best auditing tools and critical points for monitoring. And lastly, in the last session, Caroline Bilen will talk about training and education initiatives to enhance infection control best practices in endoscopy in the Middle East. And we will end this webinar with Q&A session. So without further delay, let's start with our first speaker, Jill Holdsworth from USA, Manager of Infection Prevention at Emory University Hospital, Midtown. Jill has started working as an infection preventionist in 2009, and she obtained her CIC after 1 year. She became a fellow of EPIC in 2016. Jill was the president of the DC EPIC chapter in 2014-2015, and 2016 EPIC National Emergency Management Committee Chairman. She is currently the AMI Protective Barriers Committee co-chairs. She has a lot on her CV. She is also certified in sterile reprocessing and, in sterile processing and was the 2022 HSPA Certification Council Chairman. Jill is currently serving on the EPIC National Board of Directors. Jill, welcome, and the floor is yours.
Great, thank you so much. And I'm going to share my screen now. Okay, great. Thank you guys so much for having me. And I'm hopefully going to kind of set the stage for this this entire event today, and really talk about why do we have failures in endoscope reprocessing? Why is it so hard to reprocess a scope? And why do we need more solutions? Why do we need to talk about having better workflows, better IFUs or instructions for use? Why do we need to keep talking about this topic? This is such an important topic. And once I get done with my few slides here, if you weren't sure before that this was a very difficult process, then I hope that you are convinced after these next few slides. So I'll jump right into it. So let's first talk about all of the steps that we have to take to reprocess just one scope. So if you work in a location where they're wanting to turn scopes over quickly and very fast, and they want them back really quickly, it's just not possible. And the reason is we have all of these steps that have to be completed, and they have to be completed correctly. So there isn't any hurrying that can be involved in this process. So we have to make sure that pre-cleaning is occurring and it's occurring correctly. And oftentimes, if I'm the one that's in the reprocessing room, I may not have complete control over what's going on at the pre-cleaning. And so that's where someone like myself, an infection preventionist or a leader in the department, really has to pull a team together to make sure all steps are being followed. And this oftentimes is why it fails, because you have to have somebody that's helping pull everything together and tie a nice bow on all of these steps. So is the pre-cleaning happening, and is it happening correctly? So important. If pre-cleaning isn't happening, I'm going to show you some photos in a moment, you'll get things that continue to stay inside the lumens of these scopes, and they can stay in there for a really long period of time. You have to do your leak testing, you have to do your manual cleaning, and you have to do them correctly, and you have to do them every single time. A lot of times we do that quality testing after manual cleaning, which I'll talk a lot about in a minute. We do the rinsing, we do the visual inspections. A lot of borescoping is starting to happen, which I'll talk about again in a moment. After that, we either do our high-level disinfection or sterilization. Again, a lot of steps happening there. We rinse, we dry. Sometimes we dry in our HLD machine. Sometimes we dry outside, and I'm going to talk about some failures with drying. And then we have to store them. We have to store them correctly in cabinets that actually are compliant. And then we have to make sure we're keeping track of how long we store them. We can't just store them for years and then pull them off the shelf and reuse them. So there's a lot of steps to follow. So if you weren't sure how many steps there were to follow, there's probably some additional smaller steps in here that I'm just skipping because they're smaller, and there's disposable components and things that need to be taken off, and things that need to have these little micro components that are done. These are just kind of the bigger steps, and this is already enough. So let's talk about those point of use tasks. This is so important, and I have seen this not happen correctly so many times. This happens at the bedside or at the procedure table. So one thing that we oftentimes forget is that proper handling is so important at the bedside. This could also be inside your clinic space. So if you are overseeing clinics, if it's an ENT clinic, an endo clinic, does everybody in that clinic know how to handle a scope? Are they signed off on a competency on how to handle a scope? These scopes can be damaged so easily. And if somebody has never been taught how to handle a scope, they're going to damage the tips of those scopes very easily. And then when they get down to the reprocessing space, they're going to fail the leak test and then have to be sent out for repair. And you're going to add up a lot of unnecessary costs. So again, proper handling, leak testing is so important, because then if it's not leak tested, it could get missed. So all of these steps become very, very important. The point of use treatment, if flushing is required, all of that becomes very important steps. Are those being followed? Is somebody actually observing to make sure that they're done correctly? Are hand washing sinks being used, which they shouldn't be? Are they being used to rinse off scopes, or to do something in a clinic space or somewhere before they get down to the reprocessing space? And then that communication and handoff is really important. And I see this fail a lot as well. Do those scopes sit somewhere and then finally make it to the reprocessing space at the end of the day, after they've just sat there and having things dry on the scope all day long? And then you have to do an extended soak. Do you know what you're going to use for an extended soak? How long you're going to do an extended soak for? What do the IFUs say? Is any of this on this slide actually communicated to the reprocessing room when it gets there? And I've seen this done really well, and I've seen it done really poorly. So if you don't have a good communication tool or a way to communicate it all, or even track this, you have to have a good mechanism to do that. There's all kinds of tags and communication handoff tools, but you also have to be prepared to do something about it. Once you get a good way to communicate this, then when you find out you're not making it in the 1 or 2 hours, depending on the IFUs, then you have to make sure that you're ready to put in an action plan to get them to be transported correctly. Then are you removing those single-use items that you have on your scopes? Removing them before you're reprocessing them. And then I highlighted the transport to decon within the time frame, because this can severely back up your department. And whether you're doing this at SPD or a GI reprocessing area, or a private reprocessing area in a clinic space, if you're not getting it there in the time frame and you're having to do an extended soak each time, it's going to back up the space a lot. And a lot of the reprocessing areas in an endoscopy space, it's not set up to have an additional sink to do that extended soak. It's usually a 2-sink area. There's not a third sink to do an extended soak in. So proper workflows and doing it right is imperative. So let's look at this photo really quickly. You can see inside this lumen, there's some kind of glob of something that's been left in there for who knows how many times. So how did we find something like this? We have to use a borescope to find something like this. So if you're using borescopes, if you're not using borescopes, it's a good idea to start using borescopes. Otherwise, you're not going to know what's lurking inside these lumens. You have to have a plan on how often you're going to use them, when you're going to use it, and making sure that you're going back and re-cleaning afterwards. But you also have to have a plan for what happens when I see something. When you see something like this, you can't say, okay, there it is, send it on through, because we can't see something like this and then figure, and just keep using it. So now we need to figure out, how are we going to get this off? What are we going to do? Extended soaking first. What if it doesn't come off then? And talk to the vendors and say, what if we have something in there and we can't get it off? Can we send it to you? What are you going to do? So borescoping is the only way you're going to know if you've got brush bristles that might be stuck in there or something else. So cleaning difficulties can happen, and sometimes you're not going to know unless you're looking inside these lumens. And so borescopes have really opened our eyes up to a lot of issues that we kind of knew were already there. We suspected we were having issues, that we could have things that were kind of getting stuck in there and not coming out. But now that we have borescopes, we can actually see what's happening in there. And drying difficulties, we have been able to see better with borescopes. And we did a study on this. I've put the link in here. I can also put it into the chat when I'm done talking. We did a study with Ofsted and Associates about how dry is dry after there's a 10-minute drying cycle in your AERs. And we found a lot of droplets that are still in these scopes. So when we think that they're dry coming out of your AERs, they're not that dry. And so this is quite alarming. You can see some of the photos we took with the borescope and the lumens of some of these scopes. And what you see on the blue cards down here is what we blew out with turbulent air onto these cards that caught water. So water and droplets inside these scopes, they can cause bacteria to grow if they sit in there while it's hanging in these cabinets. So this study shows how much water can really still be sitting in these scopes even after that approved 10-minute cycle in these AERs. And so looking at the higher risk endoscope, so as if it wasn't hard enough what I've already talked about, we look at some of these higher risk endoscopes when you are reading Amy's guidance for ST91. Some of these scopes have reprocessing manuals over 100 pages. So if you want to do it right, you've got to read all 100 pages and make sure you're following all of those IFUs. You have all of these different accessories that you're supposed to use to do it correctly. The brushes that you need to use, different diameters, different lengths. You need a lot of different things to do the cleaning processes correctly for the IFUs. And then the purge volumes, the pre-cleaning and the cleaning, and all of the adapters. So cleaning these scopes and doing them correctly, it is not easy if you are going to follow the IFUs, which we need to. But to do that, it is so difficult, and it's difficult on our techs. And we really need to figure out a better way as an organization, as a profession, to make it easier, but still make it a safe process. So as we move on into the next sections of this webinar, we need to ask ourselves some questions. So we know that the reprocessing procedure is very complex. We need to ask ourselves how many people know how to reprocess just because it's part of their job description, or how many people do we feel like are really competent to do these reprocessing protocols? And how many times do those people have the opportunity to do these complex procedures? And does that make them competent? Are they competent because they got signed off on a competency once, because they did return demonstration once? And then what we worry about a lot is what happens after 4 or 5 o'clock, what happens on the weekends or the holidays, or when the GI reprocessing people leave and it has to be kind of the backup person, or when the one person who's really competent goes on vacation, and then the backup person has to come in who really doesn't know what they're doing. Do we let them clean the scope with that 100-page manual? So these processes are so complex, and this is the kind of stuff that keeps me up at night. And I know a lot of other people are thinking about these things when they stay up at night. So there's a lot of things that we need to do better in this realm and on these topics. So this whole webinar speaks to me and speaks to my heart with the things that we need to be better at for the people doing this work, so that we can make sure that our patients are safe. And that is my last slide. And I believe Basil is after me, and hopefully my teammates on this webinar will share some great solutions with us. So thank you all.
Thank you, Jill, for this amazing presentation. And we will keep the Q&A to the last session, okay? Now we will have our next speaker, Basil Mulaib. who is joining us from King Saudi Arabia. Basel is the healthcare advisor and trainer for the Compass Health Consultancy in Saudi Arabia. He is an internationally recognized expert in infection prevention and control, IPC, with more than 14 years of experience. He is the EPIC 2023 Hero, a fellow of EPIC, and the Shia 2019 International Ambassador. Basel has served as an IPC consultant for several organizations, including the World Health Organization, WHO, Eastern Mediterranean region, EMRO. He holds a Master of Public Health from the American University of Beirut and the CIC designation for CBIC. Basel, the floor is yours.
Thank you, Natalie. Welcome everybody to this webinar. Thank you, Jill, for addressing the challenges. So taking things from there, my part will be covering what we have as evidence-based best practices for endoscopy processing. I know that it is too short to summarize all of these in such a small session for today. But those will serve as eye-openers for everybody joining us, and also an area for discussion if you have additional thoughts in that regard. So moving forward, talking about endoscopic procedures, we know that we have multiple potential sources of infection related to endoscopic procedures. Those could be of endogenous source coming from the patient's own flora. And we have exogenous sources, which include the pathogens associated with contaminated or inadequately reprocessed equipment or supplies. So while scopes represent a valuable diagnostic and therapeutic tool in the modern medicine, and the incidence of infection associated with the use of such scopes has been reported as low, we are having more healthcare-associated outbreaks that are linked to contaminated scopes than any other medical device. So if you go through literature, you can check that over the past several years alone, there have been greater than 25 outbreaks of multi-drug resistant organisms, and mainly also including CREs in major hospitals in the US and around the world, that have killed many patients and caused morbidity in hundreds more. So these outbreaks have been linked primarily to contaminated duodenoscopes that are used to diagnose and treat the diseases in the liver, the bile ducts, and the pancreas. And also GI endoscopes and bronchoscopes have been associated with far more outbreaks of infections, more than 130 outbreaks, than any other reusable medical or surgical device in healthcare. And 9 of these outbreaks occur despite appropriate cleaning and high-level disinfection. So up to 8% of patients undergoing ERCP, which is a procedure in endoscopy, may develop an infection due to contaminated duodenoscope. And 42% of ERCP centers, which was studied in a Dutch study, reported at least one contaminated duodenoscope after reprocessing. So talking deeper about the causes of these failures in scope reprocessing, and as Jill addressed in the challenges, those causes are multifactorial and could include defective equipment, as we saw in the borescope image, inability to access the elevator channels during cleaning and disinfection processes, especially for the duodenoscope, inadequate cleaning and disinfection of endoscopes between patients, contaminated water rinses, contaminated automatic endoscope reprocessors, biofilm generation, and endoscopes or AERs, inadequate cleaning and disinfection and sterilization of endoscope accessories, in addition to contaminated multi-dose vials, needles, syringes, or other items used during anesthesia or patient care. So prevention and control of infections associated with endoscopy depend on multiple factors, including the education, the training, and the skill of the practitioner, the integration of the device, ensuring that the equipment at first stage is free from defects, in addition to strict adherence to reprocessing protocols. And evidence-based practices are essential to be followed, and those would include updated practice-specific recommendations related to endoscope use. And we have references for those from international organizations like AURN, AMI, APIC, and SHE, in addition to education, which comes as a major element. So everyone involved in the reprocessing of the flexible endoscopes should be knowledgeable of the current issues, the challenges which are faced in endoscopy, including also the most recent instructions for use, the IFUs, and regulatory protocols and the information and the policies and procedures in the endoscopy suites. So let's talk first about the endoscopy environment. So creating a safe environment includes adherence to the infection prevention standards and the regulatory requirements and following practice-specific evidence-based guidelines. So coming to the physical design, it's an essential element in addition to the workflow of the endoscopy area, which should reduce the risk of cross-contamination and provide a safe environment. Endoscopy personnel are at risk of exposure to patient-generated infectious material through splashes or other contaminants in the environment, in addition to chemical exposure. So it is critical that the proper personal protective equipment shall be available and used in the proper manner. So what about the parameters for the endoscopy unit in terms of design? So each area within the endoscopy unit should have a designated flow for the safe physical movement of dirty scopes that do not cross-contaminate with the clean scopes, which will come out of the cleaning process and will go to the storage area. This table represents the design parameters, and as you can see, we need to be ensuring in the reprocessing area we have negative pressure. The minimum air changes per hour should be 10. In addition to the procedure room, there is no requirement to have negative pressure, it's equal pressure. And a bronchoscopy procedure room where it's considered as an airborne isolation room should have negative pressure with 12 air changes per hour. So in addition to that, in the reprocessing area, we must have adequate space for reprocessing. Jill mentioned about the enough space to have additional sink if we need to have extended soaking. So this is important to address the adequate space, the appropriate airflow and ventilation from selection and the method of the disinfection and the chemical sterilant that is used, and appropriate storage area, which follows the proper workflow. Reprocessing areas should be accessible only to authorized personnel. The workflow should be unidirectional. So we mean by that movement from the dirty to the clean area in order to minimize the opportunity for cross-contamination. And the dirty and clean areas should be physically separated from one another. And when reprocessing occurs in two rooms, the decontamination room should have negative airflow, and the temperature, in addition to the humidity levels, should be in compliance with the local and facility requirements. So the following are key elements to consider in the endoscopy environment. For sure, food and drinks should be prohibited from both patient care areas and the medical device reprocessing areas. Heating, ventilation, and air conditioning should, in the endoscopy, should be in compliance with the regulatory agencies and local building codes and the policies and procedure and the accreditation standards. In addition, patient care areas, procedure rooms, and operating rooms must be cleaned and disinfected after each patient. And when a procedure room or the patient care area is in use, it should be terminally cleaned at the end of the day. And there should be schedule for routine cleaning for the areas that are not terminally cleaned, and should be this determined through the policy that you have in your suite. with the exception of the point of use cleaning, reprocessing of contaminated equipment should be performed in a separate area or room, not in the endoscopy procedure room. Now, talking more about the environment, let's address the water issue. So water hardness is an important element we need to be aware about. So hard water used in final rinse in the AER cycle may cause deposits on the endoscope. And these deposits will act as potential focus for soiling and recontamination of the endoscope. And it may also seriously affect the optical system of the endoscope. Temperature is important of the water. So too high temperature during initial flushing stage may lead to the coagulation of the proteins, and they cause the fixation of the protein soiling on the surface of the endoscope. So you need to be referring to the manufacturer instructions for use to select the optimal temperature to be set that is required for the detergent and disinfectant that is used. In addition to that, the chloride concentration, so water that is used in cleaning and disinfection of the flexible endoscopes should have a chloride concentration between 0 and 120 milligram per liter to avoid the risk of corrosion on steel and plastic components of the endoscope. And lastly, the microbial contamination. So the water supply that is coming to the endoscopy, especially to the AR, should be treated using filtration and should be RO water in that manner. Now, in the following slides, I'll be addressing in a quick way the general steps for endoscope reprocessing. As you know, proper reprocessing is essential to prevent healthcare-associated infections. And the complexity of the reprocessing involves pre-cleaning, cleaning, disinfection, sterilization, drying, and storage. So all these are considered complex milestones in order to end up with a safe to use and disinfected scope. So starting with the pre-cleaning, this must be done in the procedure room immediately after the removal of the insertion tube from the patient and prior to disconnecting the endoscope from the power source. It should be performed at the point of use before bioburden has an opportunity to dry and before complete decontamination using the enzymatic detergent. So pre-cleaning of each device should be based on the IFUs. Keep this in mind. Leak testing is the next step. It should be performed after each use and before use of a new, repaired, or a loaned endoscope. Leak testing must be done in accordance with the endoscope and leak testing equipment IFUs. If it is done in the automated method or the manual method. So what happens if you have leak testing failure? So you need to remove it from service and send for repair or replacement. You should not proceed to reprocess it as it might damage the scope. And you should be careful to prevent environmental contamination during the handling and transportation of the scope after failing the leak test. So what about the manual cleaning? It is an essential practice before the before the automated disinfection or the manual one. It is the most important step in removing the microbial bioburden from the endoscope because failing to do that, it will cause failures in disinfection or sterilization in that manner. So IFUs should be followed. The proper time frame for reprocessing must also be respected. If there is a delay in the reprocessing, also you need to be applying the IFUs in that manner. And the area where the manual cleaning of the scopes occurs must have the optimal lighting and magnification and additional aiding tools to ensure that the lumens and all the surfaces of the scope are being checked properly. So in that process, in the manual cleaning, the sink that is designated for scope cleaning is filled with a detergent that is compatible with the endoscope as per the IFUs. You should disconnect and disassemble endoscope components like the suction valves, as far as possible, and completely immerse the scope and the components in the detergent. And definitely IFUs should be followed for the proper dilution, the temperature, and the contact time. And in that manner, the scope should be meticulously cleaned with the entire endoscope having its accessories, the valves, the channels, the connectors, and all the detachable parts according to the IFUs, using specific and convenient brushes and items for cleaning. So the next step would be the high-level disinfection. It is achieved either manually or through the automated endoscopy processor. So AERs provide a superior cleaning and decontamination, improving the rinsing of disinfectants and reducing residual disinfectants in the endoscope as compared to the manual process. High-level disinfection is the recognized minimal standards for semi-critical flexible endoscopes according to the Spalding classification. So at some instances, sterilization of endoscopes may be indicated, and this happens when the endoscopes are used in a manner that meets the definition of critical medical devices, like getting into a sterile field with potential contamination. At that instant, the endoscopes should be considered for sterilization. Keep in mind that the endoscopes are heat sensitive and cannot withstand steam sterilization. Therefore, they must be sterilized using low temperature methods, for example, ethylene oxide or hydrogen peroxide or ozone sterilization as a mean for terminal or for sterilization. And this should be validated as per the IFUs. And the scope and its accessories should be cleaned and dried per manufacturer's IFUs before the sterilization. And it is important to ensure that the moisture has been removed prior to sterilization, because presence of such moisture in the lumens may interfere with the sterilization process. So next comes the drying and storage. Those constitute the final steps in the reprocessing. So drying greatly reduces the possibility of recontamination of the endoscope by waterborne microorganisms. Drying must be performed even if AR has a purge or a drying cycle. You need to conduct a risk assessment to ensure or decide if alcohol to be used after that cycle. You need to be ensuring that all adapters are removed. You need to dry the exterior of the endoscope with a soft, clean, lint-free towel, and dry accessible endoscope channels with a pressure-regulated instrument or pressurized air as per the IFUs. Do not attach removable parts during storage, and ensure that the endoscope should be dried after every processing cycle, whether the intention is to store the endoscope or to reuse it immediately. And keep in mind that endoscopes must be stored in a secure area, not in the procedure room. And this area should be clean, well ventilated, and dust-free. And the way that you store your scope will protect them from recontamination. So if you are following the conventional drying storage or the cabinets, you need to be ensuring that storage drying is done properly in that manner. Drying cabinets have been shown to reduce the risk of microbial contamination, so they are the best practice to be applied. Drying cabinets provide a controlled environment to help ensure that the endoscope channels remain dry. And if a drying cabinet is not available, the storage cabinet should have HEPA filtered air to allow circulation around the flexible endoscopes, and the flexible scopes must be dried prior to storage, as I mentioned. So endoscopes definitely should not be stored in shipment or containers or cases. So now, after this stage, you need to be transporting your endoscope. Transportation tools or boxes should be clean, closed containers that are non-porous, puncture resistant, leak-proof, and large enough to allow the endoscope to be coiled without damaging it. And if the transportation container is reusable, it must be cleaned and for clean scopes. Single-use container. So here are some supplemental ensuring that we have proper reprocessing of our scopes. So, and this will include, yeah, I still have a few more slides in that manner, and I will be done. So this will include the routine microbiological surveillance for endoscope, periodic sampling and culturing to detect contamination, and protocols how to respond once you have positive cultures identified. So this table gives you an overview of the current processing quality control measures, which will include the ATP test, that tests for organic residues, the boroscope inspection, and the culture method. And each one has its pros and cons and indications when it is done. So in addition to that, we have enhanced the cleaning protocols for the endoscopy environment. And for the scopes during the drying technique in that manner using forced air. In addition to use of disposable accessories, definitely use single-use items. There are also trends now to use single-use endoscopes for specific procedures. This has benefits, and in addition to that, challenges. And an important element as a major helpful method to ensure that we have proper staff training and ensuring they are competent enough to handle the scopes and do the reprocessing protocols. The competency assessment should be assessed regularly, and your staff should be up to date with the guidelines and the proper practices for endoscope reprocessing. And by this, I reach the end of my presentation. Thank you all, and over to you, Natalie.
Yes, thank you, Basil, for this amazing and comprehensive session. Now we will move to Dr. Mariette Jongbloed from the Netherlands. Dr. Mariette has over 30 years of experience in healthcare, specializing in decontamination and sterilization of medical devices. She founded and directs Deconster, which provides training, advising, and auditing services internationally. She holds a bachelor's and master's degree in European Studies from the University of Amsterdam and has additional training in management, policy, internal auditing, teaching. Dr. Jongbloed has held leadership roles, including manager of the sterilization department at St. Lucas Andreas Hospital in Amsterdam. She has made significant contributions to the academic and professional community as a guest lecturer at Stellenbosch University, and she is also she co-authored of a WHO publication on medical device reprocessing. She also co-developed a national training program on sterilization in the Netherlands. She is committed to promoting evidence-based practices and patient safety, and
Yes, hello, good morning or good evening. I'm Mariette, and yes, I'm in the endoscope for quite some years now. Most important is the decontamination of our flexible endoscopes. Why? Because they are very complicated. They have long, thin channels. We cannot inspect them. We have to brush some of them, not all of them. And then we have to dry them. We don't know exactly when they are really clean or when they are really dry. And finally, that is our key. We have to make sure it is possible, it is done. The decontamination of the endoscopes has various steps. And you see at my slide, teaching, in fact, is to the staff of the staff is the most important one. The one who is cleaning them has to know what they have to do, what they may do, how not to break the scope, the endoscope as well. And especially what for me is very important, we have to give them time. The doctor cannot rush you. They cannot shorten the procedure. It has to have a certain time limit, and you need the time to do it correctly. Second is a quality system. Of course, we do need protocols. We do updating of protocols, and we have to repeat that all 6 months, every time, when something change, or every 2 years at latest. Supervision of the daily routine of how we decontaminate would be a very important step. Everybody has a right to be checked on. Supervision is not something that is difficult to handle, but you have the right to have a supervision. You have the right to know whether you're doing a good job or not. So manual pre-cleaning, as Jill and Basra told us, the IFU is extended to sometimes more than 100 pages, and we can't know everything. Anyway, at a hospital or at the endoscope area, we have a certain possibility to work. We cannot work 100 pages each time. So manual pre-cleaning has to be in a standardized way, and we have to do always the same, at the same movements, same steps, one after another. We have to repeat it. And our colleague has to tell us, oh, by the way, you forgot now to brush, or by the way, there is another thing on it, there is a little dirt. We have to check on each other. Mechanical cleaning and disinfection is, as far as I'm concerned, absolutely necessary after the manual pre-cleaning. And also there, the manual pre-cleaning has to die immediately after use. Then we have a little time, please, a little, 20 minutes, 30 minutes. And then it has to go into the mechanical cleaning area, how we call it. Drying and storage is the next thing. Without that, endoscope is dry. We only clean, we only disinfect, we do not sterilize. There are still some microorganisms back in this endoscope, if we do like it or not. We have to dry it. And dry doesn't mean 1 drip, 2 drips, 3 drips. 1 drip is wet. Dry is no drips. And we have to take our time as well. That's why I think it has to be a mechanical drying as well. Then we have the culturing of the microendoscopes that you have to do periodically, once a year, twice a year, I don't know. We will continue to discuss it. Auditing, a very important step. Auditing once a year, twice a year, how we continue, how we validate our equipment, how you make sure that we are doing always the same thing at the right time with the right endoscope. And finally, but not last, the management of incidents. We all have incidents. We don't like to speak about it, but we know from each other that we do have them. We have to have a plan. We have to do it. Teaching of the staff. Education about microorganisms, yeah, it's fine that the staff knows what it is. Education about cleaning, disinfection. What do we do with cleaning? What do we do with disinfection? We can't do miracles. We only clean with water and soap. and we disinfect with a disinfectant, sterilant. Knowledge about the construction of the scope, the different channel, what connection are used, are they disposable, are they reusable, what can we do? We have to plan all these steps of manual cleaning, and please always at the right order. And we have to register this decontamination. We have to know whether each step has to be done, is done. Next slide, please. The quality system, we have to develop our protocols. We have to write it down. We have to have a meaning of communication. How can we teach the stuff how to do it? But how can we know it ourselves? What channel has to be brushed? What channel has to be flushed? The leak test, of course. Manual pre-cleaning directly after use, as soon as possible, after 5 minutes, after 20 minutes, but certainly not after 2 hours. If that happens again, we need a protocol how to deal with it. Extensive soaking, it has to be in a protocol. Mechanical cleaning, disinfection, drying, storage, and then last but not least, again, the reparation. Scopes are very difficult devices, they will break down. Supervising of the daily routine, peer review, as I told you, we have to know the fixed order of the different steps so we can help each other, and auditing at least once a year. Mechanical cleaning and disinfection, process release, whether the machine did the right thing, validation, measuring once a year by knowing the temperature, knowing the concentration, knowing the time, as well from the mechanical cleaning, as well as the drying cabinet has to be validated. Next one, please. Periodically, culture of the endoscopes. Quite a difficult theme to address because we do not like it. What are we doing if it is positive? We have to define it. We have to know it in advance. What we will do with this culture with the dirty endoscope. It is dirty. We cannot change it. We have to discuss the method of cultivation with the laboratory where we send this fluid. We have to know what to do. Again, that is something Jill certainly knows everything about. It's difficult for the staff at the endoscopic service, but the infection prevention knows how to do, and they will manage it to do a good plan and we do cultivate the most difficult endoscope twice a year, only as control for our work. Do we do it right? Do we miss some steps? And if the most difficult endoscopes are clean, I hope that the most easy one are as well. Last, again, but not least, auditing of the yearly validation. Auditing is when your, next slide, please. Auditing, I put on the diagram here, our system, how we do audit. I'm doing that myself with one of our staffs, and we follow all the steps, what we have to do. First, policies and cleaning. Do we have it in order? Then certainly at 1.4 you see all accessories used in sterile body cavities are sterilized. Our rules ask that everything has to be sterilized, disinfected or sterile at the highest way possible to achieve. So if it can be sterilized, it has to be sterilized. Except when I think the valve, we do not sterilize the endoscopes. Why would we sterilize the valves? I think it's not really important. I accept it. The document there are documented is in written. Not possible for me. You can't have documents in written somewhere in the service where some notes are there. All the documents has to be in the quality system and has to be ordered in the same way. All accessories are clean and possibly disinfected in the department. A list has to be present which medical devices are there and which has to be treated in which way. When you have then some points where it's no, you have to give priority to when repairs are needed. If it's checked whether what priority to give you, in what order they have to better things, to adapt things. Next one, please. Manual handling of flexible endoscopes. We in Holland, in the Netherlands, we accept that an endoscope which is not dried can be handled, can be used 4 hours after mechanical disinfection. But then it cannot be kept longer as these 4 hours. After these 4 hours, it has to be returned and it has to be disinfected again. No problem. We put an hour on it. For our services, no problem. Manual pre-cleaning of endoscopes, and there 3.2, you see, the protocol is present and easily acceptable. And when you are then auditing and you ask staff, where is the protocol? Oh, yes, she didn't, no, she didn't, Sorry, the protocol has to be there, has to be present, and she has to know it. And in fact, nowadays, she has to sign that she saw it. Priority immediately, please, has to be done. Only water, no soap solution in the treatment room. That is something that also for me in the treatment room where the patients are, I don't want to have any soap because I don't want to have a suction of soap into the patient. Next diagram, please. Transport, it has to be closed, no problem. It has to be dry when it's going to the patient, and it has to be closed when it's coming from the patient to the disinfection room. I think for us at this moment, we do not work on more than 3 locations. It can be handled. Next one. Drying storage. Drying storage has to be cleaned every day. Once you take an endoscope out, you have to clean and to disinfect the storage cabinet. This drying cabinet, by the way, we use a drying cabinet as well as storage cabinet. That it's not really necessary. You can also use the drying as a drying cabinet to dry and then put it into closed boxes. It's fine with me as well. And you can keep it for 1 month. After 1 month, the scope has to be mechanically disinfected again before use. Next one, data registration. You have to register all the steps that you are doing and who is doing it, which patient, which doctor. So a recall has to be possible when something, our superbugs appears or something else can always appear. There are a lot of people working and mistakes can be made. So be aware and realize it. Hygiene, aseptic working is observed. You have to control, to check on each other. Staff, next slide, please. Staff expertise. Everybody has to follow some formation, some education in between. At least 1 formation each 2 years. Otherwise, they are not able anymore to work with the endoscopes. And it has to be written and it has to be in the personal dossier, how do you call it, in personal papers, that you have done it. You have to have a certificate. An audit, again, here also priority, and you have to follow, the department has to follow up this priority. Otherwise, also, next slide, please. Recommendation, if they can't do it, they has to stop working. I stopped one worker because they didn't have a certificate. So sorry, no work anymore. You can do the cleaning or you can help each other, but not anymore any endoscopes. You're doing that once, and people learn to follow up protocol. Then for last, sorry, Natalie, I will finish soon. That is the incident. There are incidents. We all have incidents. Specialists assessing the problem, danger for the patient. Can we do a recall only if the registration has to be done? Information of the authorities. You have to inform the Minister of Health. Maybe you have to decide it. Prevention of future similar incidents is for me almost the most important things. How to prevent not to make mistakes. We all do, but at less as possible. That is my presentation for here. Thank you for your attention, and please tell us when we have more questions. Natalie is taking it over. Natalie, you are muted.
Yes, sorry. Thank you, doctor, for this amazing presentation and for highlighting critical elements and monitoring in infection prevention in endoscopy. As announced earlier, we will keep the questions till the end. So now let's welcome our last speaker, Caroline Bilen, founder and CEO of the Compass Health Consultancy in UAE. She is recognized as a passionate clinical educator. She is a health advisor and leader in the industry with a robust medical foundation and an extensive 35-year career in healthcare management and accreditation. She holds BSN and OR certifications from AORN. She is certified in infection control and is a green belt. She is also a certified quality officer and risk management officer from the American Institute for Healthcare Management. Throughout her career, Caroline has held significant roles, always with the patient's best interest at heart. From operating room nursing manager to director of home care in Lebanon, and scientific affairs and education manager in the CEMEA regions, she has been a strong advocate for patients. She is an active international speaker and a published author and has been awarded prestigious honors and certifications. In 2019, she founded the Compass Health Consultancy firm to support healthcare organizations and professionals in capacity building through training, certifications, and achieving excellence in the Middle East region. Caroline, the floor is yours. You are muted, Caroline.
Good evening, everyone. Thank you, Natalie, for introducing me, and a special thanks to our speaker for the valuable information shared tonight. In my presentation today, I will discuss strategies for enhancing healthcare system through capacity building approach in endoscopy management, and explore ways to overcome challenges and present a framework for upskilling healthcare professionals to improve patient safety and outcome. As you can see, when we talk about capacity building, it's about improving the skills, resources, and processes that people and organizations need to succeed and adapt in a rapidly changing world. In healthcare, capacity building is essential for ensuring systems adapt to changing needs and deliver top-notch care. It involves three key aspects, starting by enhancing capacity and competency. This involves providing ongoing education and training to ensure healthcare providers are skilled and up to date. Second, improving infrastructure and system, and this entails upgrading facilities, equipment, and processes to facilitate efficient and effective care. And last, fostering continuous learning, and this promotes a culture of ongoing learning and development to support continuous improvement. Here are the benefits of adapting capacity building approach in healthcare settings through training and education. There is no doubt capacity building directly leads to enhanced patient care. Through specialized training, healthcare professionals develop skills, and that can help them to really ensure to provide accurate diagnostic, effective treatment, and improve outcome. Moreover, ongoing training ensures adherence to vital protocols, reducing errors and preventing infections. Furthermore, specialized training equips healthcare workers with the knowledge and skills to minimize healthcare-associated infection, protecting both patient and staff. Capacity building also promotes efficient use of resources, reducing waste and improving overall healthcare delivery. Ultimately, a highly skilled workforce attracts more patient and talented professionals, enhancing the organization's reputation and sustainability. Here are the main presented challenges in capacity building in endoscopy. As you know, lacking of updating infection control standards and training continuously is one of the challenges. Second, limiting funding, and this is to train the people working in the endoscopy setting is one of the challenges. Staff commitment to practices in busy endoscopy units is another one. High turnover rates make standardization, training, and infection control difficult to achieve. Resistance to new practices complicate implementation and updated measurement. And last, lacking on assessing the impact of training on outcome can be a complex too. But the good news is that once we implement an effective infection control measures in the endoscopy units, we can reduce the risk, improve patients' outcome. Infection control measures in endoscopy are not just the role and responsibility of infection control team. Everyone in endoscopy settings, from doctors to nurses, has a part in preventing infections for every patient, every time. Despite advancement in technology, the success of endoscopy procedure is still depending on the skills and the training of healthcare professionals. To elevate infection control standard endoscopy, staff must be well-trained and continuously updated with the latest knowledge and techniques to minimize errors and deliver superior patient satisfaction and outcome. Implementing a capacity building framework will definitely help to upskill healthcare professionals in endoscopy settings, enhancing their career growth as well. To do this, we should start by knowledge assessment to understand the team's gaps in infection control knowledge and the techniques and the skills. And we have a foundation, we have a baseline about their knowledge. Second, we need to focus on ongoing training, education. We need to give them certification training program as per their needs, highlighting the new technologies, best practices, and we should have a library where we have all the infection control measures, protocols, guidelines, keeping updating them. And this will help them to be up to date with their knowledge and skills. Leadership training programs are also important to equip team leaders with the skills needed to manage the team and offering mentorship and career development opportunities. And last, collaboration and partnership are crucial. We need to involve key stakeholders such as healthcare provider, infection control expert, and regulatory bodies in the capacity building process. Seeking external expertise supported as needed will also enhance the effectiveness of infection control initiative. To effectively evaluate the impact of capacity building framework, we need to consider these approach. We need to track first the healthcare associated infection before and after implementation, recording complication or patient harm related to endoscopy procedure, establish a baseline for protocol adherence and comparing result, conducting surveys to measure patient perception of care quality, do surveying to the staff to assess their satisfaction with the training, the resources, and what type of area we need to remove and improve. And using surveys, interviews, or focus group to get input from everyone involved in endoscopy management to see what's working and what is not working. It is advisable to consider the following before choosing a training program. Ensure the program is accredited by a recognized organization. Select programs that align with needs and your professional vision and goals. Look for programs that offer opportunities for practical training, quizzes, and simulation. And choose a program with experienced and knowledgeable instructors. At the Compass Health Consultancy, we are committed to capacity building through training and certification. Our mission is to train, retain, and upskill healthcare professionals in the region. We aim to empower healthcare professionals with certified training programs to meet their needs and support their career development. That's why we partner with universities and international organizations such as AORN, Patient Safety Movement to Achieve Zero Harm, the American Institution for Healthcare Management, and partnering with CPD UK to ensure all our courses adhere to highest international standards. And we adopt the capacity building framework approach in our training program to enhance the skills of healthcare professionals, especially for endoscopy team. We always start with knowledge assessment to identify gaps and accordingly tailor the program that meets the needs for empowering them to excel. We offer a range of specialized certified training programs to advance infection control practices and meet the needs of healthcare professionals. Based on the need for specialized training to advance practices in endoscopy management, we have developed certified courses that provide participants with the up-to-date guidelines, best practices, and protocols to improve their skills and ensure safety and quality in endoscopy. The course is available online in class training and will start the first one on October 3rd. We offer as well various of leadership training. We need to have leadership training to support professional development and career advancement, such quality officer and risk management. And this all will help individuals in their managerial role at all levels. At the end, we need to provide them a career development. And at the Compass as well, we always focus on continuous collaborating with partner with international organizations and universities to advance the practices and support career development in the region. At the end, capacity building through training and certification is the cornerstone of advancing healthcare excellence and empowering professionals to achieve safety and quality in patient care. As we wrap up, here are the takeaways that I need you to think about. Focusing on capacity building always will enhance the healthcare system. Training healthcare professionals is an investment in safer healthcare. Addressing endoscopy challenges lead to more effective and consistent practices. Capacity building frameworks support long-term success in endoscopy and in every healthcare settings. Empowering our endoscopy team with ongoing training and certification keep them updated with the latest knowledge and technologies, improving outcome and supporting their career growth. Collaborating and partnering with external experts help healthcare organizations achieve excellence. We at the Compass Health Consultancy are here to assist healthcare professionals and organizations in reaching that level of excellence. Thank you all for your time and attention. Let's continue to work together to achieve excellence in healthcare practices.
Thank you, Caroline. It's amazing talk. I guess we have a few minutes now left for Q&A session. Someone is asking if we will be able to share the slides. So as announced earlier, we will be sharing the recording of this webinar. And we have now two other questions. Okay. The first one, I guess Jill answered in the Q&A box. I don't know if you would like to elaborate. They asked the ideal reprocessing method for transesophageal echo and vaginal probes.
Yeah, so I can share what I put in the chat for everybody. So for TEEs and vaginal probes and several other things, there's a new guidelines document from Amy called TIR 99. And if you haven't had a chance to review that, there's also a lot of great information in that on percutaneous procedures you're using ultrasound for the guided percutaneous procedures, and what kind of disinfection that you're using with that, whether it's low level or high level. But that is a newer document that just came out this year. So if you have not had a chance to review TIR 99, I do suggest that that you do that. It also includes dilators. So this is guidance that I think we all needed for a really long time, because there wasn't anything kind of in writing on TEs, vaginal probes, percutaneous procedures, all those things that we really needed. So take a look at that. That's kind of all the best practices for everything that was left out of the other standard documents, and it's all rolled into this TIR document.
Thank you, Jill. The second question is about flexible endoscope used in ENT clinic. Is the same order should be used for decontamination before being sent for sterilization? And advise how we can do it, how we can audit this also. I guess the question perhaps is for Dr. Mariette. I don't know.
Auditing, in fact, you have to do following your own protocols, following your own steps. All the steps of each protocol can be audited. But you have first to fix it, and you have to have some norms or some guidelines who helps you to define whether it's important on what is important on these definite steps. Yes, you can audit that.
And for ENT, it's the same order?
It's the same order. It's all the same.
Okay, okay. Thank you. My question, I have a question for Caroline. If she can tell us about courses that are available at this moment and training in the region. Are there many courses that we can look at and select what is appropriate for us, or this topic is still challenging as a training topic?
This depends of the level of the competency. You know, there is people really still struggling with the basic to achieve the knowledge. So I think any organization wants to know what the training is needed. They need to assess the knowledge of their team.
Need.
Yeah, definitely. Their gaps, what area they need to improve. And in the Compass Health Consultancy, like I said, we developed a program with the up-to-date guidelines and practices. And this program will help the participant to be up to date with the best practices that can help them to excel in the endoscopy settings. We're starting the course in October in 3 sessions online. We'll be announcing soon the information. Definitely, there is one thing I want to say. There is always area to improve. I think every person, needs to ask himself, what do I need? Be open to talk to his manager and identify the gaps that he has. We should not be shy. And I think the management should as well recognize the leadership role here to upgrade the knowledge of the supervisor to the manager. You know, everyone wants to reach to the next level. And this
Yeah.
we can help them too as well.
Thank you, Caroline. I have a question for Dr. Jungblut about sharing the audit results with the staff, the concerned healthcare professionals, and how do you make sure that improvement actions that you suggested and that you agreed upon have been undertaken? Dr. Mariette, are you with us? Okay, so perhaps I have another.
Sorry, I'm there.
Yeah.
Yeah.
Yes, of course, they have to give me by in a written how they want to change what and how they want to get the change that I ask. And there is a time limit on, as I 2 months, 3 months, maybe 2 weeks, or immediately. And then I will have to go back if it's important enough and to check on it. An audit is not finished the moment the audit is the main audit is finished. It has to be followed up.
Okay, okay. Thank you, doctor. Someone is asking about culture. I don't know if we already answered that. Please, I need to know if we need to do cultures from the scopes. How would it be? You highlighted this, Dr. Jamblut. It is, I guess, still controversial, this point here. Taking swabs, where are the areas to be considered considering the next webinar? Is it for free? Okay, so let's talk about swabs and cultures first.
Swabs and culture, I discussed, I told you that you have first to discuss with your laboratory what you can put in the culture, how many milliliter of water, of rinsing water, of if you have a swab, and how quick you have to give it to your laboratory that they can follow up correctly. You have to discuss it with your laboratory how to manage that in a correct way. Otherwise, you can't do something with the results, and that would be pity.
The one thing that I would say about culturing is I would use it as your last line of defense. If you're going to go to culturing of your scopes, I would make sure that you have done everything else that you know of that is in that like quality system. Have you used a borescope? Have you used a protein testing or something that's a protein, carbohydrate, hemoglobin combined testing? And have you acted on all of those? Because if you're jumping to culturing, you should have kind of done everything and had an action plan that has conquered all of those other things first, and kind of you're out of options at that point, because there's simpler, less cost prohibitive things that you can do to get to the same end goal rather than culturing. And you can get to them a lot easier, in the moment. So culturing should be kind of that last line of defense. We don't need to jump to culturing just because it's fancier and it gives you something with a longer word. We can get kind of that same result and get the same action plan going with something a lot simpler and a just-in-time kind of result that says, yes, there's protein still here, so we need to reclean, or we need to consider this a failure, or do a borescope and say, yep, there's bioburden still in here. It needs to be recleaned, without going through the whole culturing process.
Okay, thank you, Jill. Someone is asking how to disinfect the camera, the endoscopy camera.
I think that's for Jill, yes.
Are they talking about the borescope, do you think?
No.
No, the camera, the main dock that is outside.
Yeah.
Oh, well, I would say, oh, you always have to follow the IFUs. I know that's a cliche answer, but I don't want to give an answer without knowing what is compatible with your just specific advice. So I pull the IFUs for everything. And if you don't have an electronic database that you can pull that from, you can always ask the rep for the IFUs for that. But I would definitely make sure that you're using something that is compatible with the materials that that your specific device that you're cleaning is able to be used for. Or
Okay.
otherwise you can void the warranty, and you definitely don't want to do that. And I definitely don't want you to point back to me and say, well, she said this on a webinar. So consult your IFUs.
No, of course not. Jill, another question for you. It's a wonderful session. Do you think ATP test for scope cleanliness is recommended for any reason?
Yeah, so what I would say is what is recommended is that you do something for quality testing. It doesn't have to be ATP, but what I would say is consider what you feel like would be the best option for you and your facility. If ATP is best for you, fine, but that does require you to have a baseline and a threshold. Is something that may be easier is to do something that's just a simple protein test. That you can do on site. There are combined protein, hemoglobin, carbohydrate testing that you can do in the moment. But something like that, doing it, like once every fifth scope or something like that is a great way to start a quality assurance program and seeing how many fail, and then making sure that you have a good process in place to say, and if we fail, this is what we're going to do. We're going to re-clean. If we fail again, this is what we're going to do if it fails a second time. So you can't just start a program like that and not expect to fail. You need to have a full risk assessment kind of plan in place so that you know what you're going to do if it fails once, if it fails twice, and you're going to send it back to the manufacturer if you just can't figure out what's going on. You're going to borescope it if it fails twice, if you have a borescope. So I would pick something and then pick what frequency you're going to do whatever it is you pick.
Okay. I think we have a minute for one last question. The question is for Dr. Mariette. Do you not perform manual brushing, flushing on endoscope channels? Do you rely on the AER for the cleaning? Dr. Mariette?
She's muted.
Ah,
Yes, we do. We brush and flush all the channels, especially we do it even mechanically during the manual cleaning. We brush it twice and we flush it every channel for 30 seconds. Absolutely necessary.
okay, okay. Thank you, doctor. Thank you, everyone. I guess we reached the end of our webinar. And thanks for our amazing speakers. It was a pleasure to have you all with us. Thank you all for attending this outstanding webinar. We hope you have enjoyed it, and we look forward to having you in our future webinars. Please follow us for upcoming activities on LinkedIn and other social media. Stay tuned. Bye.
Bye. Thank you so much. Have a good evening.